Yes. So, Dr. Lawrence, thank you for sitting down and talking with us. We deputized Dr. Nguyen to be an interviewer for the cancer letter. It's an adjunct position. Um, let's go back to 1971. What were your thoughts about the National Cancer Act, and why did you decide to seek NCI Cancer Center designation for MCV?
Well, thank you for having me. I would say that back in 1971, most of the support in terms of research support and emotional support, in a way, for cancer programs at universities really was organizations like the American Cancer Society. Although here in Richmond, we had the Virginia Federation of Women's Clubs and the local Masons outfit and other organizations were very supportive, but none of these could provide the kind of support that our friendly government could do. So the thing that was exciting about the National Cancer Act, which I think was one of the best things President Nixon did among things that weren't so good, was that it did bring the federal government into the funding of various kinds of research. And so we were pretty excited here when we had a lot of people at the basic science level and at the clinical level who all wanted to work together and collaborate, but having a cancer center funded by the government would really be helpful in that regard. So the National Cancer Act really gave us a lot of enthusiasm about the future of getting more things done in terms of improving the whole problem of cancer overall, patient-wise and in the laboratory.
What did it take to make it happen, to make the NCI designation happen in Richmond?
Well, in 71, it's different than now, I can tell you, because then the government group working with the idea of cancer centers really were hung up on the fact that you had to have authority that made you more or less independent of a lot of the other administrative people at the school. So many schools, the deans or the departmental chairman had their nose out of joint by having another new organization that was taking over some authority. But the advantage here in Richmond were that the deans, and at that time, the departmental chairman and everything, were gung-ho about having this new kind of coordinating entity. Now, it wasn't suddenly going to give us a lot of money for our research and other activity. What it was going to do was to give us those kinds of support funds that would help coordinate what was already funded on its own merit. So, and we did have a number of basic investigators and clinical investigators here at the time, all of whom had various kinds of research grants, sometimes through the American Cancer Society, some through the federal government and various parts of the NIH. So having this additional funding source of a coordinating entity really was exciting for both the basic scientists we were collaborating with. I say we, those who were clinical people dealing with cancer, and the basic science people who suddenly felt they were going to have some clinical advantage come from the work they were doing in the research labs.
When did you get designation?
Well, we put in we had a planning grant that helped us. I must admit they were very helpful in getting our heads straight on how to go about it. We put in our core grant in 74, and it was approved in 1975, and that time we became a NCI grant. Now, I'm glad you mentioned that, because the other thing that happened at that time, a lot of little commercial outfits, if they did a little cancer work, and they would call themselves a cancer center. So being called an NCI Cancer Center was a big deal difference, because you could just go down the street and call yourself a cancer center if you treated a few patients. And of course, the NCI Cancer Center was, in those days, was primarily research, both basic and clinical. It didn't really cover clinical treatment programs. We just had to have those as a background for having this wonderful coordinated cancer center. But the main thing was to get funded, and to be named a cancer center like we were required us having grants. And we did have a number of grants, some from the NIH and some from the American Cancer Society. And I think we measured up, because we both had, and we also had administrative support at the vice president and dean level and departmental chairman level, everybody saying it was a good idea. So I think that emotional support we had was also very helpful.
Mm-hmm. So this happened at the same time as Alabama, really the first batch of cancer centers.
Yeah.
Right? Yeah. Oh, wow. So maybe we should just go back. So you're coming to Richmond. You're from the Midwest. You've been in New York a long time. What brought you to Richmond?
Well, actually, it's really not the cancer deal at all. I spent 15 years, my first career at Memorial Sloan Kettering, and I was really excited about working there in both research and in clinical work. Ran one of the services there, and but in those days, the only dialysis unit for kidney dialysis was Memorial, none of the other universities. So it turned out that when kidney transplantation was started here in Richmond by Dr. Hume, he couldn't take our patients very well who had renal failure. So I ended up, by being a young surgeon, they said, well, why don't you start doing transplants here? So I did all the first kidney transplants as sort of a side issue of my cancer work at the Cancer Center, and got to know Dr. Hume. And Dr. Hume needed a vice chairman to answer the phone and to run things, because he was around the country all the time selling kidney transplantation. So I came down here as a transplanter, but I quickly shifted because my big deal was really cancer work. So I told Dr. Hume I could be his vice chairman if he would let me start an entirely different separate cancer service called the Division of Surgical Oncology. And he said, whatever you want, whatever you want. So I really came here interested in getting a cancer surgery going, and had no idea when I came of wanting to start a cancer center.
Wow.
Yeah.
That's been great. So, you talked a little bit about the National Cancer Act and its founding in 1971. What did the National Cancer Act accomplish for patients, for cancer patients in Richmond and the country and worldwide?
Well, actually, I think the National Cancer Act was really mainly benefiting those people who were doing research. And there was much less concentration on patients. On the other hand, you had to have a substantial relationship with the management of cancer patients for you to get funded.
Mm-hmm.
And in a way, I think the way the cancer patients actually benefited, besides us possibly getting much more knowledgeable about how to manage their care, was the fact that it did allow us to really get going on clinical trials. Randomized clinical trials that were the only way we had of really improving patient cancer care. Things like the one that Bernie Fisher in Pittsburgh started, the National Surgical Adjuvant Breast and Colon Project. And we were big. I was a good friend of Bernie, so we were a big producer in his program. And so by starting that clinical trials program here as part of the Cancer Center, I think it benefited patients quite a bit. And actually our grant from the NIH at that time was for introducing minority patients, because as my head of radiotherapy at that time pointed out, 50% of Richmond were African American. And so we were an ideal place to bring in more minorities into the trials, because the trials up to that point were somewhat in question because they didn't include the balance of people who live here in America.
Wow, wow. So, so you have a lot of distinctions, and a number of them.
Oh, you're just going on. Yeah.
But one of them is really has been really something that has motivated me from when I was a medical student and certainly a resident. You were one of the few surgeons, white surgeons, who were active in the Black Academic Surgical Association. Could you talk about that just a little?
Well, actually, I snuck in. There is a very distinguished group of surgeons called the Black Academic Surgical Society. It's a national organization with lots of surgical leaders in it. And one of the major leaders in that was LaSalle Lafall, who recently died. He was in Washington, and he was at Howard, and he was chairman of surgery there, but he was also a nationally known cancer surgeon. And LaSalle happened to get his training at Memorial when I was a junior doctor, so I started training him sort of, but we became mainly friends over the years. And due to LaSalle and a number of other members of that organization that I was friends with, to be nice to me, they made me an honorary member. So naturally, if you get to be an honorary member, you better go to the meeting every year. And it was very worthwhile because they're a wonderful group of people and continue to be. And it's quite a national organization that I'm proud of being an honorary member of.
Well, thank you. So this question, there has been a change at VCU Massey recently. They had a new appointed cancer center director. I think the guy's name is Dr. Wynn. Is there any reflections you have on my being in this position, and any advice that you would give to this new cancer center director?
Yeah, well, that's a tough one. That's a tough question. Well, first of all, I must state here, I'm excited that you're the new director, but not because you're a minority or anything else. It's because of what you've done and what you bring to the Cancer Center. Dr. Wynn is very well known for his work in pulmonary work. And everybody in the world knows that our leading cancer, that's our biggest problem still, is lung cancer. So having somebody who has a special research interest in pulmonology is especially good. The second thing especially good is, since came here, you've got so much energy and zip that I'm sure you're going to rev things up even further. So we're looking forward to great things from you. And lastly, the fact that you are African American means that we're going to be guaranteed to have diversity in our workforce. So we're winning on all levels on this thing. So thank you for coming.
Well,
and incidentally, he's from the same hometown that I came from. He didn't really grow up there. He came from somewhere in the East, but both of us are from Chicago, so we're straightening out these Southerners a little bit.
Yeah. You've treated, well, you've certainly treated some. You certainly have seen a lot of polio in your career. You have gone through the HIV era, and now there's COVID. What has the COVID pandemic told us about the U.S. healthcare system?
Oh, well, first of all, I might say that this COVID epidemic is so much more overwhelming than all those previous problems, at least from the standpoint of public perception and my public perception. The polio hit us when I was mainly a kid, and the main thing I noticed was we couldn't go to the movies, and it did worry us, but we still went to school. Now, since then, we've learned a lot, and of course, we benefited a lot from the work on polio. But this epidemic is so much more overwhelming, and when you say, what did we learn? I'm really impressed with how well our medical facilities nationwide have anteed up and come through and dealt with a disease for which we have no real treatment. We have things that help, the dexamethasone and so forth, but still, it's really impressive how nurses, physicians, and other healthcare workers have really anteed up when it was needed. What's really worried me is how our culture has really not responded as well as they might, and I'm afraid it has something to do with leadership, but I'm not going to get into politics. But I think we needed a little more leadership than we seem to be getting at the present time.
What about disparities here?
About the what?
Disparities that you see in cancer and that we saw in HIV and what we're seeing in COVID. They seem to be very similar, working very similarly.
Yeah, actually, I bet this business of the disparities in both the incidence and in the severity of all these things it's sort of a mixed bag. Some of it may well have genetic aspects, but most of it is more in the social realm. And a lot of it probably has to do with underrepresented minorities having less satisfactory social systems. So we have it's bringing to our attention the fact that we have to do a lot about that. And I'm hoping now with some of the recent activity that's gone on that we will get improvement.
So it seems that almost after every sort of big event, after polio, after HIV, and certainly after COVID, that people get fatigued. People have the protest, people have the energy, and then all of a sudden it sort of goes away. Do you think that there'll be any difference after this COVID crisis is over?
Of course, we all say we hope so, but I honestly think so. It's sort of another similar situation is that little young girl that sailed across the Atlantic on climate change. I think the younger generation may have a lot more pizzazz in response to seeing some of the awful things that are happening, that the younger generation may have more impact on how we do things than our elderly one and your middle-aged one. So I am. The other thing is with the cell phones and that, a lot of us were really had some of these things brought to our attention much more dramatically than before. Watching the killing of somebody on your phone is just pretty earth-shaking. And I think some of these things may have a lot more impact than things in the past. So I'm hoping we certainly deserve to get more benefits because this epidemic is so much worse than all the other ones.
Yes.
What are your thoughts as you navigate Monument Avenue in Richmond these days? I hear Jeff Davis is not there anymore, and a few others might be coming down.
Oh wow! You know, it's really, when you go there, it's really impressive, um, and it's amazing how so many of us were totally insensitive to the harm and the injury that those monuments did give to certain parts of our population. We looked at them as nice historic, artistic things that dolled up the avenue. But I think all the recent demonstrations, mainly peaceful, have really awakened a lot of us to how much those things did hurt. So even though we've lost some of the beauty temporarily by losing some artistic monuments, I think we've got real progress already in that dimension by having them removed. And I think I have confidence that we're going to have other things to doll up the street and make us just as proud as before. But it'll take a little time. And of course, I again want to emphasize, I think we're not going to solve this racism problem by just getting rid of monuments, but it really is a first step that I think is important in this whole procedure of improving the relationship of certain parts of our population in every way.
Well, let me just disagree with you on one point, which is that I don't think you're giving yourself enough credit, because you really we're very sensitive to these matters all along, as your career shows, and certainly a lot of people regard you, and I'm one of them, as a civil rights hero. So given that, maybe I should ask you if you ever expected that in your lifetime you will see an African-American director of Massey Cancer Center.
You know, it's an interesting question, but, you know, it never occurred to me one way or another, but now that it's happened, I'm just as excited about it. But it just wasn't one of those things. Now, one of the reasons I never really thought about too much is that even in my retirement, I was head of admissions for the medical school for a while, and we were always trying to encourage minority groups admission to the school, but we never really accomplished as much as we wanted to because there weren't enough applicants. And the reason they weren't enough applicants is if we're going to develop somebody like Dr. Wynn, we got to start improving things at the kindergarten level and not wait till they go to medical school or wait till they go into the faculty of medical school. And of course, solving this whole problem of racism in this country is going to require repairing a lot of our systems.
So going back to science and the impact of the NCI cancer centers, you know, what's been the thing for you, the one either miracle drug or the one surgery, or maybe it's a combination of the surgical approaches or the medical approaches? I think when I began my career, for example, I know that we were not really enthusiastic or there wasn't any real hope in like curing lung cancer, really treating lung cancer. So what were some of the big wow moments when you were a cancer center director? What are the big wow moments since?
Well, I have to admit, when I was in surgical training, one of the things that led me to being interested in cancer was that I thought the operations that we did for cancer were the most interesting operations we did. And as a young surgeon, they were sort of thrilling because they were some of the bigger ones. And of course, at the time I entered into this cancer field, which was in the early 50s, I'll have to admit the only good treatment for most cancers was surgery. So so as I go along here, what excites me about the future? What's exciting me about the future is the fact that we finally begin to see where there are some it's happened right along, of course, but we now begin to see that there's some real excitement about things like immunotherapy. And this is only the last 10 years that this thing we always wanted to have happen is happening. And so the thing that's exciting is that the non-surgical, or at least non-destructive methods of treating cancer have a big hope now for the first time. And we were really looking forward to immunotherapy when I started in the 50s, but it never seemed to work out. It was a good idea, too bad it didn't work. And there have been breakthroughs in cancer research in this last decade that are now being profited from in terms of developing. Now, it's not developed yet, but it is in the process of development at the Cancer Center. And it's, I think the work there is exciting for the future, and I think you're going to do it.
Thank you. So, you know, I was thinking about from where you started to where we are now about the impact of technology in the field of cancer. And do you have any reflections about, because there's always this battle about too much technology. Is it really working? Is it, you know, is it just snake oil? But it's clear that the technology all along, whether we're talking about robotic surgeries, whether we're talking about, how has technology sort of added?
Okay. Well, when technology hit surgery, that's when laparoscopic surgery, robotic surgery, and those things came along. And of course, those of us who had been doing something another way all along resisted a little bit, but it became clear that there were tremendous advantages. There's been some disadvantages. Part of the disadvantages is the increase in technology has increased its subspecialization. So many of the people treating patients have shifted from being, in a sense, physicians to technologists. And they only do one kind of treatment, and they suddenly lose sight of the disease and all its aspects and focus more on the mechanics of treatment. But it's sort of it's one of those things that goes with the territory. I think that all in all, the technology of some of these improvements in surgery, for example, have really made this a less damaging treatment and one that's better tolerated. And so it is progress overall. It just has a few of those things that make me worried. Now, that's part of the reason I still teach medical students, because I don't spend time teaching them how to treat cancer now. I teach them how to take care of people. That's still something that's very necessary in cancer management. And I'm sure you do that well.
Paul, any other questions from you?
Good. Thank you so much.
Well, thank you. I'm flattered that you would think I know anything at the age of 95. Thank you very much.
Thank you.
Paul, thanks again for doing this. Appreciate it.